Hello class. Today we will be covering Chapter 6, Mucokinetics and Surfactants. The learning objectives for this chapter are: define key terms related to mucokinetic and surfactant agents. Describe the production, function, and clearance of mucus in the healthy lung. State the indications for bland aerosols and mucolytic agents. Compare and contrast the mechanisms of action of bland aerosols and mucolytic agents. Describe how surface tension relates to oxygenation and work of breathing. Describe the role of surfactants in the lungs and surfactant replacement agents. Describe the mechanisms of action of expectorants and antitussive agents. In this slide we see trachea, main bronchi, and the branching of the respiratory tree. The trachea begins at the level of the 6th cervical vertebra and in an adult extends for about 11 centimeters to the 5th thoracic vertebra. It divides there into the right and left mainstem bronchi, one for each lung. The point of tracheal division is called the carina. Inspired air becomes 100% saturated with water vapor and is warmed to body temperature, which is 37 degrees Celsius, after it reaches the second or third airway subdivision below the carina. The point at which this occurs is known as the isothermic saturation boundary. Above the isothermic saturation boundary, the temperature and humidity of gas in the airways fluctuate, decreasing with inspiration and increasing with exhalation. Below the isothermic saturation boundary, gas temperature and humidity remain constant at body temperature and 100% relative humidity. Cold air or mouth breathing moves the isothermic saturation boundary deeper into the airways, but never by more than a few generations. 8 to 20 regularly spaced, rigid, horseshoe-shaped cartilages form the anterior part of the trachea. Stretched across the open posterior ends of the tracheal cartilages, a ligamentous membrane forms a flat dorsal surface abutting the esophagus. This membrane contains horizontally oriented smooth muscle called the trachealis. Contraction of the trachealis pulls the ends of the horseshoe-shaped cartilages closer together, slightly narrowing the trachea and making it more rigid. Rigidity of the trachea is important for preventing its collapse from external pressure, especially during vigorous coughing. Coughing exerts a collapsing force only on the part of the trachea inside the thoracic cavity, the part below about the 6th tracheal cartilage. Above this level, the trachea is outside the thorax and thus not influenced by intrathoracic pressure. At the carina, the right mainstem bronchus angles only 20 to 30 degrees away from the midline, forming a more direct continuation of the trachea than the left mainstem bronchus. The left mainstem bronchus breaks away more sharply, forming a 45 to 55 degree angle with the vertical tracheal midline. The left bronchus is smaller in diameter than the right, but twice as long. The cartilage of the mainstem bronchi resembles the cartilage of the trachea initially, except that cartilage completely surrounds the bronchi at their entry point into the lung tissue, and the posterior membranous portion disappears. As the bronchi continue to branch, the cartilage becomes more irregular and discontinuous, no longer encircling the airway in complete sections. All airways from the trachea down to the level just before the terminal air sacs, or alveoli, first appear are called conducting airways, that is, the piping system that connects the trachea and alveoli. No gas exchange between air and blood occurs across airway walls. Conducting airways merely direct air to the alveoli, which collectively comprise the gas exchange membrane of the lung. Beginning with the trachea, each of the conducting airways undergoes dichotomous branching until 23 to 27 subdivisions are formed. Beyond the third generation of airway divisions, the bronchi enter the lung parenchyma, the essential supportive tissue that composes the lung. Elastic fibers of the parenchyma surround and attach to the airways along their length. The natural recoil forces of these fibers act as tethers that hold the airways open during forceful exhalation. These tethering forces also limit the degree to which smooth muscle contraction, in other words, bronchospasm, can narrow the airway. Diseases that weaken lung parenchymal recoil forces make the airways prone to more severe narrowing or collapse, such as occurs in COPD, especially during exhalation. The natural elastic recoil forces of the lung are extremely important in keeping the small, non-cartilaginous airways open. The conducting airway subdivisions produce approximately 1 million terminal microscopic tubes at the level where alveoli, which are the gas exchange units, first appear. This enormous degree of branching creates a massive increase in the combined cross-sectional area of the airways from the trachea to the gas-exchanging alveolar surface, which is approximately 50 to 100 meters squared, which is half the area of a tennis court or about 40 times the surface area of the body. This is a sputum bowl question. An intricate engineering design is required to distribute air uniformly and rapidly through millions of tubes of various lengths and diameters without creating too much frictional resistance to air movement. The design of the tracheobronchial tree is so efficient that an airflow rate of 1 liter per second, which is commonly achieved during arresting inspiration, requires a pressure difference of less than 2 centimeters of water pressure between the trachea and alveoli. In addition, the volume of gas left in the conducting airways after an inhaled breath must be relatively small so that most of the breath reaches the alveolar gas exchange membrane. The volume of conducting airway gas, including the upper airways, is only about 150 milliliters in the average adult, compared with a total inhaled volume per breath of about 500 milliliters. Because the conducting airways do not participate in gas exchange, they are commonly known as anatomical dead space. The rule of thumb you should know is 1 ml per pound of ideal body weight, or approximately 1/3 of a normal tidal volume. Bronchioles are airways less than 1 millimeter in diameter that contain no cartilage in their walls. Their patency depends on the tethering retractile forces of the lung's elastic parenchymal tissue. Bronchial and bronchiolar smooth muscle is oriented in a circular, spiral fashion, facilitating airway narrowing when it contracts. Strong smooth muscle contractions or spasms may nearly collapse the bronchioles, especially if disease weakens the lungs' opposing elastic tethering forces. In contrast, tracheal smooth muscle is transversely oriented between the two ends of the trachea's crescent-shaped cartilages. These cartilages limit the ability of smooth muscle contraction to narrow the tracheal diameter. At the 19th or 20th generation, the terminal bronchioles divide to form several generations of respiratory bronchioles, marking the beginning of the respiratory, or gas exchange, zone. The respiratory bronchioles are tubes containing thin, sac-like pouches, alveoli, in their walls. Alveoli are the gas exchange membranes that separate air from pulmonary capillary blood. Alveolar ducts open into blind terminal units called alveolar sacs and alveoli. The airways branching off of a terminal bronchiole are collectively called the acinus, which is the functional respiratory unit of the lung. In other words, each terminal bronchiole gives rise to an acinus. Conducting airway histology. A mucus-secreting epithelium, mucosa, lines the lumen of the conducting airways. A basement membrane beneath the epithelium separates it from the lamina propria below, which contains smooth muscle, elastic fibers, blood vessels, and nerves. The epithelium and lamina propria constitute the respiratory mucosa. Below the mucosa is the submucosa, which contains numerous mucus glands, which are submucosal glands, that have ducts leading to the epithelial luminal surface. A connective tissue sheath, the adventitia, surrounds cartilaginous airways and blood vessels. This sheath ends at the bronchioles. Bronchiolar airway walls are in direct contact with the lung parenchyma. Anatomy and physiology. The mucosal epithelium of the trachea and bronchi consists of tall, columnar, ciliated, pseudostratified epithelial cells interspersed with numerous mucus-secreting goblet cells. Most numerous are the pseudostratified ciliated columnar epithelia, but there are also secretory cells such as goblet cells, serous cells, and club cells. The goblet cells and submucosal mucus glands secrete mucus onto the ciliated epithelial surface of the airways, forming a mucus blanket that is continually propelled upward in the direction of the pharynx. The serous cells produce less viscous mucus, which makes up the sole layer of the mucus. The role of the club cells is not completely clear, but they are known to have a high degree of metabolic activity and to contain many enzymes. The submucosal glands contribute the greater volume of mucus. Their secretion increases under the influence of parasympathetic nervous stimulation. All epithelial cells are attached to the basement membrane, but not all of them reach the airway lumen, and they appear to be stratified, hence the term pseudostratified. Together, the goblet cells and bronchial glands produce about 100 milliliters of mucus each day. Most of the mucus is reabsorbed, but about 10 milliliters reaches the pharynx each day, where it is usually swallowed. Epithelial cells gradually flatten and lose their cilia as they proceed from bronchi to alveoli, cartilage disappears, and goblet cells gradually decrease in number and finally disappear. Other bronchial epithelial cells include basal cells, serous cells, Kolchitsky cells, brush cells, Clara cells, and intermediate or undifferentiated cells. Serous cells may transform to goblet cells if chronically exposed to air pollutants, including cigarette smoke. Cigarette smoke causes all mucus cells to proliferate and spread into the small bronchioles, where they are usually absent. Cigarette smoke also ultimately reduces ciliary activity. Kolchitsky cells are endocrine cells more prominent in newborns than adults and are apparently precursors of carcinoids and small cell bronchogenic carcinomas. Clara cells, found in the terminal and respiratory bronchioles, are non-ciliated secretory cells bulging upward into the airway lumen. These cells are normally the sole source of secretions at this level because mucus cells are absent. Their secretions apparently also form part of the alveolar liquid lining. Injury to the epithelium at this level may cause the Clara cells to differentiate into ciliated or mucus cells. The mucociliary system, or mucociliary escalator, consists of the mucosal blanket that lines the airways from the naso and oropharynx to the terminal bronchi. It also includes the cilia, which propel the mucus up the airway. Cilia are tiny hair-like projections that arise from the surface of the mucosal cells. There are about 200 cilia per cell, and they are about 6 microns in length. The cilia beat about 1,000 times per minute in a coordinated fashion to propel the mucus toward the upper airway. In healthy lungs, the mucus moves forward at a speed of about 2 centimeters per minute. As discussed last week, the mucociliary system is an important part of the pulmonary defense system. It protects the lungs from inhaled debris, and it contains enzymes that give it antimicrobial properties that help prevent infection. Mucus helps to warm and humidify inspired gases, and it prevents excessive loss of heat and moisture from the airways. It is important to note that no cilia or mucus are found in the lower airways from the respiratory bronchioles to the alveoli. The cilia stroke at a rate of approximately 15 times per second, producing a sequential motion of the cilia called a metachromal wave. The metachromal wavelength is about 20 micrometers and propels surface material in a specific direction. In the nose, this motion pushes material back to the pharynx. It moves the material toward the pharynx from the bronchioles to the larynx. This action is commonly referred to as the mucociliary escalator. This mechanism allows inhaled particles to be removed within 24 hours in healthy lungs. The control and coordination of ciliary motion are not fully understood and represent some of the many fascinating properties of the pulmonary epithelium. The production of mucus and the rate of ciliary beating are sensitive to various conditions and chemicals. Mucus production increases when the respiratory tract is irritated by particles and multiple chemicals and during increased parasympathetic nervous stimulation. Ciliary beating can be effectively slowed or stopped if the viscosity of the sole layer is increased by exposure to dry gas. Ciliary motion is also slowed or stopped after exposure to smoke, high concentrations of inhaled O2, and drugs such as atropine. The smooth muscle of the airways varies in location and structure. Smooth muscle is bundled in sheets in the large airways and smaller airways. Smooth muscle forms a spiral pattern that wraps the airway in bundles in decreasing quantities as the airways branch and become smaller. Muscle fibers crisscross and spiral around the airway walls. This placement reduces the airway diameter and shortens it when the muscle contracts. This pattern of smooth muscle continues but thins out on reaching the smallest bronchioles. The smooth muscle tone is increased, resulting in bronchospasm by the activity of the parasympathetic nervous system and pro-inflammatory mediator released from the mast and other cells. Check your comprehension. Goblet cells and bronchial glands produce 100,000 milliliters of mucus a day. True or false? False. The airway is made up of 5 layers. True or false? False. Bronchial smooth muscle is located in the mucosa. True or false? False. The mucus molecule itself is very large and complex. It is about 95% water, so it is imperative that there is a sufficient amount of water available in the body to produce normal mucus. Once mucus has formed, it does not absorb water readily. The remaining 5% of mucus composition comprises long, flexible strands of protein and lipid molecules that form polypeptide chains, with many carbohydrate side chains attached. The side chains are cross-connected with disulfide, physical, ionic, and hydrogen bonds. Notice in this slide where the various medications work on the mucus. These are questions you may see in the sputum bowl or board questions, as well as on your pharmacology exam. Mucus plays a crucial role in the respiratory tract by serving as a protective and functional barrier. Its primary functions include trapping particles and pathogens. Mucus acts as a sticky substance that captures inhaled particles such as dust, allergens, bacteria, and viruses. This prevents these harmful substances from reaching the lungs and causing infections or damage. Moistening the airways. Mucus helps keep the respiratory tract moist, which is essential for the proper functioning of the cilia that line the airways. This moisture ensures efficient movement of mucus and trapped particles out of the respiratory system. Facilitating ciliary clearance. The cilia in the respiratory tract beat in a coordinated manner to move mucus, along with trapped debris and pathogens, upward toward the throat. This process, known as the mucociliary escalator, helps clear the airways and protect the lungs. Immune defense. Mucus contains antibodies, enzymes, and antimicrobial proteins. For example, lysozyme and immunoglobulins that help neutralize or destroy pathogens, providing an additional layer of immune defense. Lubrication. Mucus reduces friction in the airways, making it easier for air to flow during breathing. In summary, mucus is vital for maintaining respiratory health by trapping harmful substances, facilitating their removal, and supporting the immune system. The mucociliary system and the respiratory tract can be significantly affected by various diseases, leading to impaired clearance of mucus, increased susceptibility to infections, and compromised lung function. Here we will discuss the effect of various respiratory disease and its effect on the mucociliary system. 1. Acute and chronic bronchitis. In acute bronchitis, there is inflammation of the bronchial tubes due to viral or bacterial infections. It results in excess mucus production, occurs as a defense mechanism, but it can overwhelm the mucociliary system. The ciliary function may be temporarily impaired, leading to mucus accumulation and coughing to clear the airways. In chronic bronchitis, which is part of COPD, this is persistent inflammation and irritation of the bronchial tubes, often due to smoking or long-term exposure to irritants. Hypersecretion of thick, sticky mucus overwhelms the mucociliary escalator. The ciliary function is damaged over time, leading to chronic mucus buildup, recurrent infections, and airway obstruction. Asthma is a chronic inflammatory condition characterized by airway hyperresponsiveness and narrowing. Here we see inflammation causes swelling of the airway walls and increased mucus production. The mucus can become thick and sticky, impairing ciliary movement and trapping air in the lungs. During an asthma attack, the combination of mucus hypersecretion, bronchoconstriction, and inflammation further obstructs airflow and hampers mucociliary clearance. Cystic fibrosis is a genetic disorder caused by mutations in the CFTR gene, leading to defective chloride and water transport across cell membranes. You will learn more about this disease in the fall in Mike's pathology class and in my board prep class. This disease results in the production of abnormally thick, sticky mucus that is difficult to clear. The mucociliary escalator is severely impaired, causing mucus to accumulate in the airways. This creates a breeding ground for bacterial infections, leading to chronic inflammation, lung damage, and progressive decline in lung function. Bronchiectasis is a chronic condition characterized by permanent dilation and damage to the bronchial walls, often due to recurrent infections or inflammation. The damaged airways lose their structural integrity, impairing ciliary function and mucus clearance. Mucus pools in the dilated airways, leading to chronic infections, inflammation, and further damage to the mucociliary system. A vicious cycle of infection, inflammation, and mucus hypersecretion ensues. Pneumonia is an acute infection of the lung parenchyma, often caused by bacteria, viruses, or fungi. Inflammation and immune response lead to increased mucus production in the airways. The mucus can become purulent, which is sputum, filled with pus, and thick, overwhelming the mucociliary escalator. Ciliary function may be temporarily impaired due to inflammation and infection, leading to mucus accumulation and difficulty clearing the airways. So let us summarize the effects on the mucociliary system. Disease effect on mucociliary system from acute or chronic bronchitis results in hypersecretion of mucus, ciliary dysfunction, and impaired clearance. In asthma, mucus hypersecretion, inflammation, and impaired ciliary function during attacks. And cystic fibrosis results in thick, sticky mucus overwhelms the mucociliary escalator, leading to chronic infections. And bronchiectasis results in structural damage to airways, impairs ciliary function and mucus clearance. In pneumonia, we see inflammation and purulent mucus overwhelm the mucociliary system, impairing clearance. In all these conditions, the mucociliary system's ability to clear mucus and pathogens is compromised, leading to increased risk of infections, inflammation, and progressive lung damage. Management often focuses on reducing mucus production, improving clearance, and treating underlying infections or inflammation. The mucociliary system in the respiratory tract can be significantly impaired by various factors, including thick mucus, dry gas, smoke inhalation, noxious gases, positive pressure ventilation, endotracheal tubes, high VO2, and atropine administration. I will review how each of these factors affect the mucociliary system. Thick mucus. The effect of thick mucus is that it makes it more difficult for cilia to move, impairing the mucociliary escalator. This leads to mucus accumulation in the airways, increasing the risk of infections, inflammation, and airway obstruction. The mechanism of how it has this effect is that it increases the viscosity of mucus, reduces ciliary beat frequency and coordination, slowing or halting mucus clearance. Dry gas. The effect of gas or air is that it dehydrates the mucus layer, making it thicker and stickier. This impairs ciliary function and mucus clearance, leading to airway irritation and increased susceptibility to infections. The mechanism of how it has this effect is that the lack of humidity reduces the water content of mucus, disrupting the optimal viscosity needed for ciliary movement. Smoke inhalation, or in other words, cigarette smoking. The effect of chronic exposure to cigarette smoke damages cilia and increases mucus production. This leads to impaired mucociliary clearance, chronic bronchitis, and increased risk of infections. The mechanism of how it has this effect is that the toxic chemicals in smoke paralyze or destroy cilia and cause goblet cell hyperplasia, which is an increased mucus production. Over time, this results in mucus accumulation and airway inflammation. Noxious gases. The effect of inhalating noxious gases, such as chlorine, ammonia, sulfur dioxide. It causes acute inflammation and damage to the respiratory epithelium. This impairs ciliary function and mucus clearance, leading to mucus buildup and airway obstruction. The mechanism of how it has this effect is that the direct chemical irritation and inflammation damage cilia and increase mucus secretion. Positive pressure ventilation. The effect of positive pressure ventilation is that it can dry out the airways and alter the normal mucociliary clearance mechanism. This increases the risk of mucus plugging and ventilator-associated infections. The mechanism of how it has this effect is that the high airflow and lack of humidity in ventilated gases dehydrate the mucus layer, impairing ciliary function. Endotracheal tubes. The effect of endotracheal tubes is that it bypasses the natural humidification and filtration of the upper airways. This leads to drying of the mucus layer, impaired ciliary function, and increased risk of mucus plugging and infections. The mechanism of how it has this effect is that the tube irritates the airway epithelium, causing inflammation and increased mucus production. It also disrupts the normal mucociliary escalator by physically obstructing ciliary movement. High oxygen concentration. The effect of prolonged exposure to high levels of oxygen can cause oxygen toxicity, leading to inflammation and damage to the respiratory epithelium. This impairs ciliary function and mucus clearance. The mechanism of how it has this effect is due to the reactive oxygen species, ROS, generated by high oxygen levels damage cilia and epithelial cells, reducing mucociliary clearance. Atropine administration. The effect of administering atropine, an anticholinergic drug, reduces mucus secretion and can dry out the airways. This impairs mucociliary clearance and increases the risk of mucus plugging. The mechanism of how it has this effect is that atropine blocks parasympathetic activity, reducing the activity of submucosal glands and goblet cells, which are responsible for mucus production. In summary, these factors disrupt the mucociliary system by altering mucus viscosity, damaging cilia, or reducing mucus production, leading to impaired clearance, increased infection risk, and compromised respiratory function. Managing these effects often involves humidification, reducing exposure to irritants, and supporting mucociliary clearance through bronchial hygiene therapies or mucolytic agents. Increased mucus production and impaired ciliary function can significantly impact the respiratory system, leading to a cascade of physiological challenges. Let us separate the two and discuss the effects separately. First, let us examine the role of an increased mucus production plays. Mucus is a protective substance produced by the respiratory epithelium. It traps pathogens, particles, and debris, preventing them from reaching the lower airways. When excessive mucus production increases due to infections, allergies, or chronic conditions like chronic obstructive pulmonary disease or cystic fibrosis, it can overwhelm the respiratory system. This thick, excessive mucus can block airways, reducing airflow and making breathing difficult. Blocked airways can limit oxygen intake and carbon dioxide expulsion, leading to hypoxemia and hypercapnia. This stagnant mucus becomes a breeding ground for bacteria, increasing the risk of secondary infections like pneumonia. So now let us examine the effect this has on ciliary function. Remember, cilia are hair-like structures on the respiratory epithelium that move in coordinated waves to clear mucus and trapped particles out of the airways. When ciliary function is impaired due to genetic disorders like primary ciliary dyskinesia, smoking, or infections, mucus clearance is compromised. Without proper ciliary movement, mucus stagnates in the airways, exacerbating obstruction and inflammation. Persistent mucus buildup irritates the airways, leading to chronic inflammation and damage to the respiratory epithelium. Impaired mucus clearance increases susceptibility to recurrent respiratory infections, further damaging the airways. So now we can see that both excessive mucus and impaired ciliary function contribute to narrowed airways, making it harder to breathe. The respiratory muscles must work harder to overcome airway resistance, leading to fatigue and respiratory distress. Over time, these issues can lead to or worsen chronic conditions like COPD, bronchiectasis, or asthma. Poor oxygenation and recurrent infections can strain other organs, such as the heart, leading to pulmonary hypertension or cor pulmonale, and the immune system. A persistent cough is common as the body attempts to clear excess mucus. Shortness of breath occurs due to airway obstruction and reduced lung function. Wheezing and crackles are heard over the chest as a result from narrowed airways and fluid accumulation. This leads to an increased effort to breathe and reduced oxygen levels, leading to tiredness and fatigue. Frequent recurring respiratory infections are a hallmark of impaired mucus clearance. The pharmacological treatment of mucus-related respiratory issues focuses on improving mucus clearance, reducing airway obstruction, and enhancing ciliary function. These treatments target different layers of the mucus structure, the sole layer, which is the watery layer near the cilia. It is here we will learn about the use of bland aerosols and expectorants. We will be discussing the role mucolytics play when addressing issues attributed to increase in the gel layer, which is the thicker, more viscous layer on top. We will also discuss medications which may improve the ciliary activity, which includes sympathomimetic bronchodilators and corticosteroids. Dehydration of mucus in the respiratory tract can significantly impair its function, leading to thickened, sticky mucus that is difficult to clear. This can exacerbate respiratory conditions and increase the risk of infections. Several factors can contribute to the dehydration of respiratory mucus, including environmental, physiological, and pathological causes. Here's a detailed discussion of these factors. Environmental factors, such as low humidity in the environment, especially in arid climates or during winter when indoor heating is used, can draw moisture out of the respiratory mucus. Inhalation of irritants like smoke, pollutants, or chemical fumes can damage the respiratory epithelium and alter mucus composition. These irritants can disrupt the normal production and hydration of mucus, leading to dehydration. Inadequate fluid intake or excessive fluid loss, such as occurs with fever, sweating, or diarrhea, which reduces the body's overall hydration status. Reduced systemic hydration can lead to less water available for mucus production, resulting in thicker mucus. With age, the respiratory epithelium may become less efficient at producing and maintaining hydrated mucus. Older individuals are more prone to thickened mucus and impaired clearance. With cystic fibrosis mutations in the CFTR gene, which regulates chloride and water transport across epithelial cells, leads to reduced water content in mucus. This results in mucus becomes thick and sticky, leading to airway obstruction and recurrent infections. The chronic inflammation in COPD damages the respiratory epithelium and alters mucus production. This results in mucus becomes dehydrated and difficult to clear, contributing to airway obstruction. In asthma, inflammation and increased mucus production can lead to impaired hydration and clearance. With thickened mucus, which contributes to airway narrowing and exacerbations. Primary ciliary dyskinesia is a genetic disorder that impairs ciliary function, leading to mucostasis and secondary dehydration. The mucus becomes thick and accumulates in the airways. Viral or bacterial respiratory infections can damage the epithelium, increase mucus production, and alter its composition. The inflammatory responses and cellular debris can dehydrate mucus, making it thicker and harder to clear. Medications such as diuretics increase fluid excretion, which can lead to systemic dehydration. Reduced systemic hydration can indirectly dehydrate respiratory mucus. Anticholinergic drugs reduce mucus secretion by inhibiting parasympathetic activity. This may lead to a decreased mucus production, can lead to drier, thicker mucus. As we have learned, smoking damages the respiratory epithelium and impairs mucociliary clearance. As a result, the mucus becomes thicker and more dehydrated due to epithelial dysfunction and increased inflammatory responses. When there is an insufficient fluid intake, this leads to a reduce in water availability for mucus production. As a result, mucus becomes thicker and less effective at trapping and clearing pathogens. Now it is time to check your comprehension. Cilia are found in the sole layer. True or false? True. The mucosa blanket consists of the gel and sole layers. True or false? True. The volume of thickness of mucus is generally decreased with asthma. True or false? False. Bland aerosols do not directly affect the mucus molecule, but instead dilute mucus by altering its water content. These agents are often referred to as wetting agents and include water, normal saline, hypotonic saline, and hypertonic saline. Historically, the treatment of thick, retained secretions has focused on thinning mucus by adding water or saline to the respiratory tract through inhalation. While the gel layer of mucus, once formed, is somewhat resistant to the addition or removal of water, it is crucial to ensure an adequate amount of water is available during mucus formation. This ensures that the mucus maintains normal viscoelastic properties, which refers to its ability to transition between thick and thin states. The effectiveness of bland aerosols in thinning thick mucus through topical hydration or mixing may not be as significant as once believed. Instead, their benefits might arise from a different mechanism. Bland aerosols can be somewhat irritating to the airways, though the degree of irritation varies among the different agents. In some cases, this irritation may lead to harm, depending on the patient's underlying condition. However, the irritation can also stimulate the production of thinner mucus, potentially by activating goblet cells and bronchial glands to increase mucus secretion, which is a parasympathomimetic response. Additionally, bland aerosols can enhance mucus clearance by restoring the sole layer and stimulating the cough reflex, which can be clinically beneficial in managing respiratory conditions. Bland aerosols are primarily used to hydrate the airways, reduce mucus viscosity, and aid in secretion clearance. They can be administered with or without oxygen, and are suitable for use in hospitals, clinics, extended care facilities, and home settings. Cool bland aerosols are mainly indicated for upper airway conditions such as laryngotracheobronchitis, subglottic edema, and post-extubation edema. Heated bland aerosols are recommended for patients with bypassed upper airways to minimize humidity deficits. The efficacy of bland aerosols in reducing mucus viscosity is limited, as they minimally affect the physical properties of mucus. They are not a substitute for systemic hydration, and are less efficient than heated humidifiers or heat moisture exchangers for patients with bypassed upper airways, due to difficulties in maintaining temperature and potential airway irritation. Heated bland aerosols are recommended for patients with bypassed upper airways to minimize humidity deficits. Assessment for bland aerosol therapy includes evaluating symptoms, such as stridor, hoarseness, or increased work of breathing. Desired outcomes include reduced work of breathing, improved vital signs, decreased dyspnea, and adequate sputum samples for analysis. Monitoring during therapy includes observing patient comfort, vital signs, respiratory mechanics, sputum production, and oxygen saturation. Frequency of administration varies based on the clinical setting and patient condition, with close monitoring required in critical care or emergency settings. Several methods are available for delivering water and saline to the lungs, each with distinct mechanisms and applications. One approach involves the use of humidification devices, which increase the humidity of dry gas by bringing it into contact with water. This can be achieved by passing the gas over or bubbling it through water, allowing water molecules to evaporate and humidify the gas. Another method is the use of nebulizers, which produce aerosols, which are small droplets of solution suspended in gas. When inhaled, these aerosols deposit water particles directly into the airways. A third method is the direct installation of liquid into the respiratory tract, though this is less commonly used and reserved for specific clinical scenarios. Humidifiers are often employed during oxygen therapy to mitigate the drying effects of oxygen. The amount of humidity added depends on factors such as the duration of gas-water contact, the surface area available for evaporation, and the gas temperature. Simple humidifiers are not intended to treat thick secretions, but rather to prevent the drying of the airways. Heating the inspired gas significantly enhances its capacity to carry water vapor, making heated humidification systems particularly useful in mechanical ventilation. These systems deliver gas at body temperature with 100% relative humidity, which is critical for effective pulmonary disease management. Additionally, heated, humidified, high-flow oxygen systems are increasingly recognized as beneficial for non-ventilated patients with various pulmonary conditions. Aerosol delivery is the most common method for administering water and saline to the respiratory tract. Small volume nebulizers, typically handheld, are frequently used for medication delivery and sputum induction, as they stimulate coughing. However, only a small fraction of the aerosol produced by these devices reaches the lungs. Large volume and ultrasonic nebulizers, on the other hand, can deliver substantial amounts of aerosol to the lungs, making them clinically valuable. However, ultrasonic nebulizers can produce excessively watery secretions in infants, impairing mucociliary function and likened to trying to rake water. Direct installation of fluids, such as normal saline, into the respiratory tract is occasionally performed in patients with artificial airways or during bronchoscopy. This method is highly irritating to the upper airway, often triggering a strong cough. Historically, saline installation was routinely used during suctioning to thin secretions, but this practice is now discouraged. Evidence suggests that saline installation does little to thin secretions and may dislodge bacteria from the endotracheal tube into the lungs, increasing the risk of pneumonia. The primary benefit of saline installation is its ability to stimulate coughing, making it useful in situations where patients do not cough adequately during suctioning. During bronchoscopy, saline installation is more effective, as the airway is anesthetized and more of the instilled fluid can be recovered through suctioning. Sterile water is free of microorganisms and may include additives to inhibit bacterial growth. Distilled water, on the other hand, is both sterile and pure, meaning it contains no additives or naturally occurring minerals, as these are entirely removed during the distillation process. While any solution intended for inhalation must be sterile, it does not necessarily need to be distilled. In fact, distilled water can be slightly more irritating than sterile water. Sterile water is frequently used as a diluent for aerosolized medications, in humidifiers, and large volume nebulizers. A cool mist of sterile water may provide a soothing, humectant effect on inflamed upper airways, such as in cases of croup. Humectant means a substance that promotes retention of moisture. Now getting back to our discussion, there is limited evidence to suggest that a significant amount of water reaches the lower airways. It is also theorized that sterile water, being hypotonic, is more readily absorbed by mucus and may thin mucus more effectively than saline. Nevertheless, there is little objective evidence to support the idea that either water or saline mixes well with mucus. Devices that generate very dense aerosols can be more irritating to the airways. These dense aerosols are more likely to trigger coughing or even bronchospasm, particularly in susceptible individuals like those with asthma. However, this irritation and coughing can make such aerosols useful for inducing sputum. This is why it is important to monitor the breath sounds of patients receiving aerosol treatments for sputum induction, as wheezing may indicate the onset of bronchospasm. The management of croup often involves supportive measures to alleviate symptoms, with cool mist therapy using sterile water and the use of normal saline being two commonly considered approaches. Cool mist therapy, typically delivered through humidifiers, has been a traditional method for soothing inflamed upper airways in conditions like croup. The idea behind this approach is that the cool mist helps to moisturize and calm irritated tissues, providing a soothing effect. However, there is limited evidence to suggest that a significant amount of water reaches the lower airways, and its effectiveness in thinning mucus remains largely theoretical. While sterile water is hypotonic and may be more readily absorbed by mucus, there is little objective evidence to confirm that it mixes well with mucus or provides substantial clinical benefits. One potential drawback of cool mist therapy is the density of the aerosol produced by certain devices. Dense aerosols can be more irritating to the airways, potentially triggering coughing or even bronchospasm, especially in individuals with heightened airway sensitivity, such as those with asthma. This irritation while sometimes useful for inducing sputum in specific clinical scenarios, may not be ideal for managing croup, where the primary goal is to reduce inflammation and ease breathing. Monitoring breath sounds during treatment is essential, as wheezing may indicate bronchospasm, necessitating discontinuation of the therapy. In contrast, normal saline, which is isotonic and matches the tonicity of body fluids, is generally less irritating to the airways and less likely to cause bronchospasm, compared to hypotonic solutions, like sterile water. Its physiological compatibility makes it a safer option for nebulization, particularly in children with croup. Normal saline is also frequently used as a diluent for other aerosolized medications, such as bronchodilators, due to its stability and minimal risk of adverse effects. However, it is important to note that in patients with COPD, the use of normal or hypertonic saline can lead to a decline in lung function and is not routinely recommended. The advantage of normal saline over cool mist lies in its physiological similarity to body fluids and its reduced potential for airway irritation. While cool mist therapy may provide a soothing sensation, its benefits are not well supported by strong evidence, and the risk of irritation or bronchospasm with dense aerosols limits its practicality. Normal saline, on the other hand, offers a gentler and more predictable option, particularly when combined with other medications. Both approaches aim to alleviate symptoms, but normal saline may be a more reliable and safer choice, especially in clinical settings where minimizing irritation and ensuring therapeutic efficacy are key priorities. Hypertonic saline refers to any solution with a sodium chloride concentration greater than 0.9%. The most commonly available concentrations are 5% and 10% sodium chloride. These solutions are highly irritating and are primarily used for sputum induction, especially in patients with a dry, non-productive cough. The airways respond to irritation by increasing mucus production, which can help facilitate the collection of sputum for diagnostic purposes. However, hypertonic saline is more likely to cause bronchospasm compared to other bland aerosols, making it necessary in some cases to pre-treat patients with a bronchodilator to minimize this risk. Close monitoring during treatment is essential, and the therapy should be stopped, or a bronchodilator administered if signs of bronchospasm occur. While hypertonic saline can lead to a decline in lung function in patients with COPD, it has been shown to benefit individuals with cystic fibrosis by improving mucus clearance and enhancing lung function. Hypotonic saline, also referred to as half-normal saline, is available in a 0.45% sodium chloride solution. This concentration is commonly used in commercially available solutions, designed for ultrasonic nebulizers. Compared to sterile water, or hypertonic saline, hypotonic saline is less irritating to the airways. It can be utilized in various types of large volume nebulizers, and is also suitable as a diluent for nebulized medications, making it a versatile option for respiratory treatments. The rationale for using hypotonic saline in the respiratory tract lies in its unique properties and its ability to address specific clinical needs. Hypotonic saline, such as a 0.45% sodium chloride solution, has a lower salt concentration than the body's fluids, making it less irritating to the airways, compared to hypertonic saline, or sterile water. This reduced irritation is particularly beneficial for patients with sensitive airways, as it minimizes the risk of triggering coughing or bronchospasm, which can occur with more concentrated or hypotonic solutions like sterile water. Hypotonic saline is often used in respiratory therapies because it can help hydrate and loosen thick mucus secretions. Its lower osmolarity allows it to be absorbed more readily into the mucus layer, potentially thinning secretions and making them easier to clear from the airways. This can be especially useful in conditions where mucus retention is a concern, such as in certain cases of bronchitis or other respiratory infections. Additionally, hypotonic saline is compatible with a variety of nebulizers, including ultrasonic and large volume devices, and can serve as an effective diluent for nebulized medications. Its gentle nature makes it a suitable choice for patients who may not tolerate more irritating solutions, while still providing therapeutic benefits. Overall, the use of hypotonic saline in the respiratory tract is grounded in its ability to balance effective mucus hydration and airway clearance with minimal irritation, making it a valuable tool in respiratory care. Time to check your comprehension. The volume and/or thickness of mucus is increased with cystic fibrosis. True or false? True. Among the purposes of mucus is to lubricate the airways. True or false? True. Water, saline, or expectorants increase the depth of the sole layer. True or false? True. The administration of hypertonic saline can be used for sputum induction. True or false? True. 5% saline is an isotonic solution. True or false? False. 0.9% saline is a hypotonic solution. True or false? False. Distilled water has bacteriostatic properties. True or false? False. Sterile water has bacteriostatic properties. True or false? True. Mucoactive therapy is primarily used to reduce the accumulation of airway secretions, thereby improving pulmonary function, enhancing gas exchange, and preventing recurrent infections and airway damage. This therapy is particularly indicated in conditions characterized by excessive mucus production or impaired mucus clearance, such as chronic bronchitis, cystic fibrosis, diffuse panbronchiolitis, asthma, and bronchiectasis. However, not all patients with mucus retention benefit from mucoactive drugs. Those with strong expiratory airflow and effective cough mechanisms tend to respond better. The use of mucoactive therapy to promote secretion clearance should be considered only after addressing underlying infections, reducing inflammation, and minimizing or eliminating airway irritants, like tobacco smoke. In cases of infection or dehydration, the gel layer of mucus thickens, and inflammatory waste products such as white blood cells, DNA, and cellular debris further contribute to this thickening. When mucus becomes too thick, the cilia are unable to mobilize it effectively, causing the gel and sole layers to combine, and creating a vicious cycle of increasingly thickened mucus. In such situations, interventions like humidity therapy, mucolytic agents, expectorants, or a combination of these may be necessary to break the cycle and restore mucus clearance. Mucolytics are a key component of mucoactive therapy, as they directly alter the structure of mucus molecules, facilitating expectoration by liquefying thick secretions. These agents work by breaking down the complex molecular strands within mucus, making it thinner and easier to clear. Currently, two mucolytic agents, acetylcysteine and Dornase alpha, are approved by the FDA for aerosol administration to treat abnormal pulmonary secretions. Research in this field is ongoing, and new agents may emerge in the future to further enhance the management of mucus-related respiratory conditions. Mucolytic agents work by reducing the elasticity and viscosity of mucus. Since elasticity is essential for effective mucociliary transport, these agents have the potential to negatively impact normal physiological mucus clearance. However, by transforming mucus into a more liquid state, mucolytics can facilitate the aspiration of secretions using suction catheters. The role of mucolytic agents in managing pulmonary disease has been extensively reviewed at various conferences, focused on the scientific basis of respiratory care. Therapeutic strategies for managing mucus hypersecretion involve addressing underlying causes and improving airway clearance. Where possible, causative factors should be removed, such as treating infections, avoiding all exposure to tobacco smoke, and minimizing contact with pollution and allergens. Improving tracheobronchial clearance is another key approach, which may include the use of bronchodilators to enhance expiratory airflow, particularly in conditions like asthma. Bronchial hygiene measures, such as promoting effective coughing, deep breathing exercises, chest physical therapy, and the use of airway clearance devices or techniques, can also play a significant role. Additionally, improving overall airflow through exercise and nutritional rehabilitation can support respiratory health. When indicated, mucoactive agents may be used as part of the treatment plan. These agents help manage excessive mucus production and improve secretion clearance, particularly in cases where other measures are insufficient. By combining these strategies, clinicians can tailor treatment to the individual needs of patients with mucus hypersecretion, aiming to optimize respiratory function and quality of life. Acetylcysteine is a mucolytic agent used to treat conditions associated with thick, viscous mucus secretions, such as cystic fibrosis, chronic bronchitis, tuberculosis, and acute tracheobronchitis. It works by disrupting disulfide bonds within the mucus structure, breaking down the long mucopolysaccharide strands that form a matted network of complex molecules. This action reduces the viscosity and elasticity of the mucus, making it easier to clear. Acetylcysteine's mode of action involves substituting free thiol, sulfhydryl groups for the disulfide bonds that connect mucin proteins, which prevents cross-linking between strands and reduces mucus viscosity. Its mucolytic activity is enhanced at a higher pH of 7 to 9. Acetylcysteine contains ethylenediamine tetraacetic acid, a chelating agent, and its light purple color indicates the removal of metal ions. Opened vials should be refrigerated and discarded after 96 hours to prevent contamination. One of the most significant risks associated with acetylcysteine is its potential to cause bronchospasm, particularly in patients with asthma, due to its acidic nature. Other adverse effects include stomatitis, nausea, rhinorrhea, and mechanical airway obstruction, which necessitates the availability of suction equipment for patients with artificial airways. The drug's disagreeable odor, caused by the release of hydrogen sulfide, can provoke nausea or vomiting. Prolonged nebulization may result in a highly concentrated residue that irritates the airways, so diluting the remaining solution with sterile water after 3/4 has been nebulized is recommended. Additionally, acetylcysteine can leave a sticky film on the hands or face. Acetylcysteine is incompatible with certain antibiotics, such as sodium ampicillin, amphotericin B, erythromycin lactobianate, tetracyclines, and aminoglycosides. It also reacts with substances like rubber, copper, iron, and cork. When used, acetylcysteine is typically administered as a 10% or 20% solution via aerosol or direct instillation into the tracheobronchial tree. The 10% solution is less likely to cause bronchospasm than the 20% solution, but requires larger volumes, often exceeding the optimal fill volume of most small volume nebulizers, leading to longer treatment times. To minimize the risk of bronchospasm, especially in patients with reactive airway disease, acetylcysteine is often administered after pretreatment with a short-acting bronchodilator, such as albuterol, which takes 15 to 30 minutes to reach peak effect. Other complications of acetylcysteine include rhinorrhea, stomatitis, and bronchorrhea, which result from irritation of mucous membranes and the production of excessive thin, watery secretions. Effective clearance of these secretions through deep breathing, coughing, or bronchial hygiene therapies like chest percussion, postural drainage, and positive expiratory pressure therapy is essential to prevent mucus plugging, particularly in patients with ineffective cough or artificial airways. Beyond its mucolytic properties, acetylcysteine is also a potent antioxidant and is used as an antidote for acetaminophen overdose, administered either orally or intravenously. When given orally, it can be mixed with cola, other soft drinks, or orange juice to mask its unpleasant taste. For detailed dosing information, the package insert should be consulted, and poison control centers can provide additional guidance. Overall, while acetylcysteine has potential therapeutic benefits, its use in respiratory care requires careful consideration of its risks, side effects, and compatibility with other treatments. Dornase alpha, a recombinant form of the human DNase enzyme, is a peptide mucolytic that digests extracellular DNA and reduces the viscosity and adhesivity of respiratory secretions. It was approved by the FDA in 1994 as the first mucoactive agent specifically for the treatment of cystic fibrosis. In cystic fibrosis, pulmonary secretions are abnormally thick and sticky due to defective chloride exchange mechanisms, which lead to increased sodium and water absorption from the airways. This results in thickened mucus, impaired clearance, and chronic infections. The persistent infections in cystic fibrosis patients cause a high concentration of neutrophils to accumulate in the airways. As these neutrophils break down, they release large amounts of DNA, further contributing to the thickening of mucus. Dornase alpha works by breaking down this extracellular DNA, reducing the viscosity of the mucus, and restoring its ability to flow, thereby improving secretion clearance. Dornase alpha is indicated as a maintenance therapy for managing the viscous pulmonary secretions in cystic fibrosis, aiming to reduce the frequency of respiratory infections and preserve or improve pulmonary function. It is particularly effective in patients with more severe pulmonary disease, defined by a forced vital capacity less than 40% of the predicted value. However, its efficacy has not been demonstrated for acute exacerbations of cystic fibrosis lung disease or for other chronic airway conditions, such as non-cystic fibrosis bronchiectasis, asthma, or COPD. In fact, studies have shown that Dornase alpha can worsen pulmonary function and increase the risk of death in adults with non-cystic fibrosis bronchiectasis, or COPD. This is likely because secretions in these conditions are primarily composed of mucin and related proteins, whereas cystic fibrosis secretions are dominated by neutrophil-derived DNA and pus. The mode of action of Dornase alpha involves reducing the size of DNA polymers in purulent sputum, which decreases its viscosity and adhesivity in a dose-dependent manner. It is administered via aerosol using specific nebulizers, such as the Hudson T Updraft 2, Marquest Acorn 2, Perry LC+, or Durable Sidestream, paired with compatible compressors. The drug is supplied in single-dose ampoules containing 2.5 milligrams of Dornase alpha in 2.5 milliliters of solution, typically administered once daily. For patients over 21 years of age with an FVC greater than 85% of predicted, twice-daily dosing may be beneficial. The solution should be refrigerated, protected from light, and discarded if left at room temperature for more than 24 hours, or if discolored. It should not be diluted or mixed with other medications. Dornase alpha is generally well tolerated, with minimal side effects such as voice alteration, pharyngitis, laryngitis, rash, chest pain, and conjunctivitis. Less common adverse effects include increased cough, dyspnea, pneumothorax, hemoptysis, rhinitis, sinusitis, flu-like symptoms, gastrointestinal obstruction, hypoxia, and weight loss. It is contraindicated in patients with hypersensitivity to Dornase alpha, or Chinese hamster ovary cell products, from which it is derived. Despite its safety profile, Dornase alpha is not effective for treating other lung diseases, such as pneumonia, asthma, or burn injuries, and its use in these conditions may be harmful. The clinical application of Dornase alpha focuses on improving lung function and reducing the frequency and severity of respiratory infections in cystic fibrosis patients. It has been associated with decreased use of intravenous antibiotics and fewer hospitalizations. Treatment evaluation is based on improvements in lung function, reductions in infectious exacerbations, and decreased need for antibiotics and hospital stays. Additionally, research into other peptide mucolytics, such as thymosin beta-4 and gelzolin, has explored their potential to depolymerize F-actin and further reduce sputum viscosity. While these agents have shown promise in vitro, particularly when combined with Dornase alpha, clinical trials have not yet demonstrated significant benefits, largely due to challenges related to their stability and delivery via aerosolization. Overall, Dornase alpha remains a cornerstone in the management of cystic fibrosis, targeting the unique pathophysiology of cystic fibrosis-related mucus to improve patient outcomes. The recommendations regarding mucolytics, as outlined in the AARC Clinical Practice Guideline, advise against their routine use in several clinical scenarios due to insufficient evidence of effectiveness and potential harm. Recombinant human Dornase alpha is specifically not recommended for hospitalized adult and pediatric patients without cystic fibrosis, particularly those with non-CF bronchiectasis, as there is no evidence supporting its efficacy in these populations. Similarly, the routine use of aerosolized N-acetylcysteine to improve airway clearance is not recommended, as there is no high-level evidence demonstrating its benefits in improving oxygenation, reducing ventilator time, or resolving atelectasis in hospitalized patients without cystic fibrosis. Additionally, mucolytics are not recommended for patients with neuromuscular disease, respiratory muscle weakness, or impaired cough, as there is insufficient evidence to support their use in these populations. In postoperative patients, mucolytics are also not recommended for the treatment of atelectasis, due to a lack of evidence. The guideline emphasizes that the use of mucolytics should be carefully considered, as they may cause adverse effects and increase healthcare costs without providing clear benefits. Overall, the recommendations highlight the need for well-designed clinical trials to establish the efficacy and safety of mucolytics in these patient populations. The AARC Clinical Practice Guideline provides clear recommendations regarding the use of mucolytics and expectorants emphasizing that their routine use is not supported by sufficient evidence in most clinical scenarios. The guideline highlights that the use of these agents may lead to adverse effects, such as bronchospasm, nausea, and vomiting, and can increase healthcare costs without providing clear benefits. Overall, the recommendations stress the importance of avoiding routine use of mucolytics and expectorants in these populations and call for well-designed clinical trials to establish their efficacy and safety. The guideline underscores the need for evidence-based decision-making, focusing on individual patient needs and potential risks, rather than relying on clinical assumptions or extrapolations from cystic fibrosis treatment protocols. Check your comprehension. Acetylcysteine will alter the consistency of the gel layer. True or false? True. Albuterol will improve ciliary activity. True or false? True. Expectorants are agents that increase mucus production and facilitate its expulsion by enhancing fluid levels in the respiratory tract and stimulating cough. They are commonly found in over-the-counter cough and cold medications. The mechanism of action for expectorants is thought to involve either stimulating the vagal gastric reflex, which increases parasympathetic activity, or being absorbed into respiratory glands to directly promote mucus production. Hypertonic saline, discussed earlier, is also classified as an expectorant. Among the most widely used expectorants is guaifenesin, along with potassium iodide. However, the effectiveness of expectorants remains controversial, partly due to the challenge of obtaining objective data to evaluate their efficacy. The most straightforward and frequently recommended method for maintaining mucus clearance is adequate hydration through the consumption of water and other non-diuretic fluids, while avoiding diuretic substances like tea and alcohol. Iodide-containing agents, such as supersaturated potassium iodide, are generally regarded as expectorants, believed to stimulate the secretion of airway fluids. Iodopropylidine glycerol, for example, was once thought to enhance tracheobronchial clearance in patients with chronic bronchitis, as measured by radiolabeled aerosol. However, a double-blinded crossover study in patients with stable chronic bronchitis found no improvement in pulmonary function, gas trapping, or sputum properties with iodopropylidine glycerol, leading to its removal from the market. Sodium bicarbonate, another agent occasionally used for tracheal irrigation or as an aerosol, is thought to draw water into secretions through inflammation, though this effect has not been clinically demonstrated. While sodium bicarbonate has not been shown to improve mucus clearance, it is being studied as a potential therapy for cystic fibrosis, where airway bicarbonate transport is impaired, leading to acidic secretions. Guaifenesin, often classified as an expectorant rather than a mucolytic, is believed to work by stimulating the gastrointestinal tract rather than through systemic exposure. However, it can be ciliotoxic when applied directly to respiratory epithelium. Despite its FDA approval as an expectorant in extended-release formulations, studies have shown mixed results. For instance, a large study in adults with acute infectious bronchitis found no significant differences in sputum volume, properties, or symptom resolution compared to placebo. However, another study suggested that guaifenesin, when combined with pseudoephedrine, improved symptoms of nasal congestion and sinus headache more effectively than placebo in patients with upper airway infections. It is important to note that guaifenesin may cause nephrolithiasis. Dissociating solvents, such as urea, disrupt ionic and hydrogen bonds in mucin gels, reducing mucus viscosity. However, urea's mucolytic action requires very high concentrations, making it unsuitable for clinical use. Oligosaccharides, which make up a significant portion of mucin structure, can also disrupt hydrogen bonds. Agents like dextrin, mannitol, and lactose have been studied for their mucoactive effects. Dextrin, particularly its lower molecular weight fractions, has shown potential in improving tracheal mucus velocity in animal studies. Mannitol, administered via dry powder inhaler, has been approved in Australia and Europe for treating cystic fibrosis and non-CF bronchiectasis. While generally safe, some patients with cystic fibrosis may experience bronchial hyperreactivity, with inhaled mannitol necessitating pretreatment with a short-acting bronchodilator. Mannitol is also used in bronchial challenge testing. Cough suppressants, or antitussives, are used to reduce the frequency and intensity of coughing, particularly when the cough is dry, hacking, and nonproductive. Coughing is often triggered by the stimulation of vagal sensory endings in the larynx, bronchi, or even the stomach. However, when the cough does not contribute to airway clearance, and instead causes further irritation of the nerve endings, it may be necessary to suppress it. Cough suppressants work by depressing the cough center, which is located in the medulla. These agents can be classified into opioid and non-opioid categories. Common opioid cough suppressants include codeine and hydrocodone, while dextromethorphan is a widely used non-opioid option. Another non-narcotic agent, benzonatate, chemically related to the local anesthetic tetracaine, works by anesthetizing stretch receptors in the lungs and pleura, thereby inhibiting the cough reflex at its source, without affecting the central nervous system. Its effects begin within 15 to 20 minutes and last for 3 to 8 hours. Additionally, the antihistamine diphenhydramine, which is Benadryl, is available in syrup form, and in combination with other products, can also act as an effective cough suppressant. However, individuals taking diphenhydramine should be cautioned about its sedative effects. Cough suppressants should never be used in patients with thick, retained secretions, as coughing is essential for clearing these secretions. In some cases, over-the-counter cold medications combine antitussives with expectorants, with the rationale that a less frequent but more productive cough is preferable to a frequent, dry, hacking cough. However, the practice of combining an expectorant to stimulate mucus production with an antihistamine to dry secretions is questionable. As part of the evidence-based clinical practice guidelines, the American College of Chest Physicians published their recommendation. Their document is titled, Cough Suppressant and Pharmacologic Pertussive Therapy. Here they reviewed the efficacy of various pharmacologic agents used to suppress cough or enhance cough clearance, focusing on the mechanisms of action and clinical effectiveness. The review is based on literature searches from 1960 to 2004, limited to human studies, and includes double-blind, placebo-controlled trials. The document categorizes cough therapies based on their effects on different components of the cough reflex pathway, including mucociliary factors, the afferent limb. Remember from Chapter 1, these are called sensory receptors, the central mechanism, which is referring to the central nervous system, and the efferent limb, which is the spinal motor neurons and respiratory muscles. It also discusses pertussive therapy, which aims to enhance cough effectiveness in clearing airway secretions, particularly in conditions like cystic fibrosis, bronchiectasis, and pneumonia. I will now review the key findings for the following areas listed in this document. The key areas are mucolytic agents, peripheral antitussive agents, central antitussive agents, pertussive agents, other drugs, and neuromuscular blocking agents. Mucolytic agents are not consistently effective in reducing cough in patients with bronchitis, though they may benefit patients in other ways. Inhaled ipratropium bromide is recommended for cough suppression in upper respiratory infections and chronic bronchitis, but other anticholinergic agents, like tiotropium, do not show consistent effects. Peripheral antitussive agents, such as levodopa and mogasteine, are effective in reducing cough in patients with chronic or acute bronchitis, but have limited efficacy in upper respiratory infection-induced cough. Central antitussive agents, including codeine and dextromethorphan, are effective in chronic bronchitis, but show limited efficacy in upper respiratory infection-induced cough. They suggest that the central mechanisms of cough may differ between disorders, affecting the sensitivity to these drugs. Pertussive agents, like hypertonic saline and dodostine, are recommended for short-term use to increase cough clearance in bronchitis, while amiloride is recommended for adult patients with cystic fibrosis. Recombinant DNase, though improving spirometry, is not recommended for increasing cough clearance in cystic fibrosis. Other drugs, such as zinc preparations, are not recommended for treating cough due to the common cold, due to inconsistent evidence and potential side effects. Over-the-counter cold medications, except for older antihistamine decongestant combinations, are also not recommended until proven effective in randomized controlled trials. Neuromuscular blocking agents are recommended for suppressing cough during intubation under general anesthesia, but drugs affecting the efferent limb of the cough reflex are not recommended for symptomatic relief in chronic or acute cough. They conclude that relatively few drugs are effective for nonspecific cough suppression, and their use should be guided by the underlying cause of the cough. The recommendations largely confirm and extend previous guidelines, emphasizing the importance of tailoring therapy to the specific disorder causing the cough. Now let us check your comprehension. Guaifenesin will make you not cough. True or false? False. Dextromethorphan is a cough suppressant. True or false? True. Surfactant plays a critical role in managing surface tension within the alveoli, which is essential for maintaining proper lung function and preventing alveolar collapse. Surface tension is a natural property of liquids that causes their surfaces to contract, creating a force that pulls liquid molecules together. In the lungs, this surface tension arises from the thin layer of fluid that coats the inner surfaces of the alveoli. Without surfactant, this surface tension would be excessively high, making it difficult for the alveoli to expand during inhalation and causing them to collapse during exhalation. Surfactant is produced by type 2 pneumocytes, is a complex mixture of lipids and proteins that spreads across the alveolar lining. The phospholipids in surfactant have both water-attracting and water-repelling properties, allowing them to align at the air-liquid interface. This alignment disrupts the cohesive forces between water molecules, significantly reducing surface tension. By lowering surface tension, surfactant prevents smaller alveoli from collapsing into larger ones, a phenomenon that would otherwise occur due to the higher inward pressure in smaller alveoli. This stabilization ensures that alveoli of all sizes remain open and functional. Additionally, surfactant makes the lungs more compliant, reducing the effort required to inflate the alveoli during inhalation. Without surfactant, the high surface tension would make the lungs stiff and difficult to expand, requiring much greater effort to breathe. Surfactant also stabilizes the alveoli throughout the breathing cycle, ensuring that surface tension remains low during both inhalation and exhalation. This stability is crucial for efficient gas exchange and overall respiratory function. In summary, surfactant is vital for reducing surface tension in the alveoli, preventing collapse, facilitating lung expansion, and ensuring efficient gas exchange. Its absence or deficiency, as seen in conditions like respiratory distress syndrome in premature infants, leads to severe breathing difficulties and alveolar collapse, highlighting its essential role in maintaining healthy lung function. Laplace's law describes the relationship between pressure, surface tension, and the radius of a spherical structure, such as an alveolus in the lungs. According to this law, the pressure inside a spherical structure is directly proportional to the surface tension and inversely proportional to its radius. In simpler terms, smaller spheres have higher internal pressure compared to larger ones when surface tension remains constant. This means that without intervention, smaller alveoli would be at greater risk of collapsing into larger ones, because the higher pressure in smaller alveoli would force air out, leading to their collapse. In the lungs, surfactant plays a critical role in counteracting the effects of Laplace's law. Surfactant, produced by type 2 pneumocytes, reduces surface tension at the air-liquid interface within the alveoli. By lowering surface tension, surfactant ensures that the pressure inside smaller alveoli does not become excessively high compared to larger ones. This stabilization prevents smaller alveoli from collapsing and helps maintain a more uniform distribution of air throughout the lung. Without surfactant, the high surface tension in smaller alveoli would cause them to collapse, leading to atelectasis, in other words, alveolar collapse, and impaired gas exchange. In essence, surfactant's ability to reduce surface tension is vital for balancing the pressures in alveoli of different sizes, ensuring that they remain open and functional. This is particularly important during the breathing cycle, as alveoli expand and contract. By mitigating the effects of Laplace's law, surfactant helps maintain lung compliance, prevents alveolar collapse, and supports efficient gas exchange, which is essential for healthy respiratory function. In conditions like respiratory distress syndrome, where surfactant is deficient, the inability to counteract Laplace's law leads to widespread alveolar collapse and respiratory failure, highlighting the critical role of surfactant in lung mechanics. A typical chest X-ray of healthy lungs shows clear, well-aerated lung fields with a uniform, dark gray or black appearance, indicating that air is filling the alveoli properly. The diaphragm is clearly visible, and the heart and mediastinal structures are well-defined. The ribs, spine, and other bony structures are also clearly outlined, and there are no abnormal opacities or white patches in the lung fields. The lung volume appears normal, and the costophrenic angles are sharp and clear. In contrast, a chest X-ray of an infant with respiratory distress syndrome typically shows several characteristic abnormalities due to the lack of surfactant and the resulting alveolar collapse. The lungs appear less aerated, with a ground glass or hazy appearance, indicating poor air exchange. There may also be visible reticulogranular patterns, which are fine, granular opacities throughout the lung fields, representing collapsed alveoli and fluid-filled spaces. The lung volume is often reduced, and the diaphragm may appear elevated due to the inability of the lungs to fully expand. In severe cases, air bronchograms may be visible, where the air-filled bronchi stand out against the collapsed fluid-filled alveoli, creating a branching, white pattern. The heart borders may also appear less distinct due to the surrounding lung abnormalities. Now let's take a look at the role of surfactant in respiratory distress syndrome. Surfactant is critical for reducing surface tension within the alveoli, allowing them to remain open and stable during breathing. In infants with respiratory distress syndrome, the lack of surfactant leads to increased surface tension, causing the alveoli to collapse at the end of each breath, is what we call atelectasis. This collapse makes it difficult for the lungs to expand during inhalation, leading to poor oxygenation and the characteristic X-rays seen in this slide. The reduced lung compliance and increased effort required to breathe further exacerbate the condition, often resulting in respiratory failure if untreated. Premature infants often struggle with increased work of breathing due to immature surfactant production, a condition that significantly impacts their ability to breathe effectively. Surfactant, a substance produced by type 2 pneumocytes in the lungs, is essential for reducing surface tension within the alveoli, the tiny air sacs where gas exchange occurs. In premature infants, the lungs are not fully developed, and the production of surfactant is insufficient or absent. This deficiency leads to several physiological challenges that increase the effort required to breathe. Without adequate surfactant, the surface tension within the alveoli remains high, making it difficult for the alveoli to expand during inhalation. High surface tension causes the alveoli to collapse at the end of each breath, a condition known as atelectasis. As a result, the lungs become stiff and less compliant, requiring significantly more effort to inflate. The infant must use greater force to draw air into the lungs, which strains the respiratory muscles and increases the overall work of breathing. Additionally, the collapse of alveoli reduces the surface area available for gas exchange, leading to poor oxygenation and the buildup of carbon dioxide in the blood. This hypoxemia and hypercapnia further exacerbate the infant's respiratory distress, creating a cycle of increased effort and worsening lung function. The infant may exhibit signs of labored breathing, such as retractions, grunting, and nasal flaring. The increased work of breathing also places a significant metabolic demand on the infant, who has limited energy reserves due to prematurity. Over time, this can lead to fatigue of the respiratory muscles, making it even harder for the infant to sustain adequate ventilation. Without intervention, the condition can progress to respiratory failure. Treatment for premature infants with surfactant deficiency often involves the administration of exogenous surfactant to replace the missing or insufficient natural surfactant. This therapy helps reduce surface tension, re-expand collapsed alveoli, and improve lung compliance, thereby decreasing the work of breathing. Mechanical ventilation, or CPAP, may also be used to support the infant's respiratory efforts until the lungs mature and surfactant production increases. By addressing the underlying surfactant deficiency, these interventions help alleviate the increased work of breathing and improve outcomes for premature infants. Type 1, Type 2, and Type 3 pneumocytes are specialized cells in the alveoli of the lungs, each playing distinct roles in maintaining lung function and supporting gas exchange. Type 1 pneumocytes are thin, flat cells that cover the majority of the alveolar surface. Their primary role is to facilitate gas exchange. Their extremely thin structure allows oxygen to diffuse from the alveoli into the bloodstream, and carbon dioxide to move from the blood into the alveoli for exhalation. Type 1 cells are essential for creating a minimal barrier between the air in the alveoli and the blood in the capillaries, ensuring efficient respiration. However, They are not involved in surfactant production. Type 2 pneumocytes are cuboidal cells found scattered among the type I cells, primarily in the corners of the alveoli. These cells are responsible for producing, storing, and secreting pulmonary surfactant, a complex mixture of lipids and proteins that reduces surface tension within the alveoli. Surfactant is critical for preventing alveolar collapse during exhalation by stabilizing the alveoli and reducing the effort required to reinflate them during inhalation. Without surfactant, the alveoli would collapse, leading to respiratory distress. Type 2 pneumocytes also play a role in repairing and regenerating the alveolar epithelium, as they can differentiate into type I cells if needed. Type 3 pneumocytes, also known as alveolar macrophages, are immune cells that reside in the alveoli and airways. Their primary role is to defend the lungs against inhaled pathogens, particles, and debris. They engulf and digest foreign materials, helping to maintain a sterile environment in the alveoli and prevent infections. While they do not directly contribute to surfactant production or gas exchange, their protective function is vital for maintaining the overall health and function of the lung tissue. In summary, type I pneumocytes are essential for gas exchange. Type 2 pneumocytes produce surfactant to stabilize the alveoli and support lung mechanics, and type 3 pneumocytes protect the lungs from infection and injury. Together, these cells ensure the proper functioning of the alveoli, enabling efficient respiration and maintaining lung health. The production and regulation of surfactant in the lungs is a complex and tightly controlled process, which is essential for maintaining lung function and efficient gas exchange. Surfactant is primarily produced by type 2 pneumocytes, which are specialized epithelial cells located in the alveoli. These cells synthesize, store, and secrete surfactant, which is a mixture of lipids, which is primarily phospholipids like phosphatidylcholine, proteins, and neutral lipids like cholesterol. The production and regulation of surfactant involve several key steps and are influenced by various physiological and developmental factors. The type 2 pneumocytes synthesize surfactant in their lamellar bodies, which are specialized organelles that store the surfactant components before secretion. The process begins with the synthesis of phospholipids and surfactant proteins in the endoplasmic reticulum and Golgi apparatus of the type 2 cells. These components are then packaged into lamellar bodies, where they are organized into a highly ordered structure. When the lamellar bodies are secreted into the alveolar lumen, they unravel to form a lattice-like structure called tubular myelin, which spreads across the air-liquid interface of the alveoli. This spreading reduces surface tension and stabilizes the alveoli, preventing their collapse during exhalation. The production and secretion of surfactant are regulated by a variety of factors, including hormonal, mechanical, and developmental signals. Hormones such as glucocorticoids and thyroid hormones play a significant role in promoting surfactant production, particularly during fetal lung development. Glucocorticoids stimulate the synthesis of surfactant phospholipids and proteins, while thyroid hormones enhance the maturation of type 2 pneumocytes. These hormones are critical for preparing the lungs for breathing at birth. Mechanical forces, such as lung stretching during fetal breathing movements, also influence surfactant production. These movements help stimulate the differentiation of type 2 pneumocytes and the secretion of surfactant. After birth, the physical expansion of the lungs during breathing further promotes surfactant release. The levels of surfactant in the alveoli are regulated by feedback mechanisms involving surfactant proteins. These proteins help regulate the recycling and reuptake of surfactant by type 2 pneumocytes, ensuring that surfactant levels are maintained within an optimal range. Excess surfactant is taken up by type II cells, broken down, and reused, while damaged or non-functional surfactant components are cleared by alveolar macrophages. Surfactant proteins are a critical component of pulmonary surfactant, which is produced by type II pneumocytes in the alveoli of the lungs. These proteins, along with lipids, make up the surfactant complex, which is essential for reducing surface tension and maintaining alveolar stability. Surfactant proteins are divided into two main categories: hydrophilic proteins, which are known as SPA and SPD, and hydrophobic proteins, known as SPB and SPC. Each of these proteins has a unique structure and function, contributing to the overall effectiveness of surfactant. Composition of surfactant proteins. SPA and SPD, hydrophilic proteins. Now let us discuss the composition of the surfactant proteins. SPA and SPD are large, water-soluble proteins that belong to the colectin family. They have a collagen-like region and a carbohydrate recognition domain, which allows them to bind to pathogens and participate in immune defense. These proteins are not directly involved in reducing surface tension, but play important roles in innate immunity. They help recognize and neutralize pathogens, such as bacteria and viruses, and modulate inflammatory responses in the lungs. SPA protein also plays a role in organizing surfactant lipids and proteins at the air-liquid interface, contributing to the structural integrity of surfactant. SPB and SPC proteins are. These proteins are small, lipid-associated proteins that are essential for the surface tension-lowering properties of surfactant. SPB is a highly conserved protein that plays a critical role in the formation and stability of the surfactant film at the air-liquid interface. It helps organize phospholipids into a functional monolayer, which is necessary for reducing surface tension and preventing alveolar collapse. SPC is a highly hydrophobic protein that integrates into the surfactant lipid layer, enhancing its stability and spreading across the alveolar surface. SPC also contributes to the reuptake and recycling of surfactant by type II pneumocytes. The proteins, SPB and SPC, are essential for the surfactant's ability to reduce surface tension. Without these proteins, the surfactant would not form a stable monolayer, and the alveoli would collapse during exhalation, leading to respiratory distress. By reducing surface tension, surfactant proteins help maintain alveolar stability, ensuring that the alveoli remain open and functional during the breathing cycle. This is critical for efficient gas exchange. The proteins, SPA and SPD, contribute to the lungs' innate immune system by recognizing and neutralizing pathogens, preventing infections, and modulating inflammation. This protective role is especially important in the delicate environment of the alveoli, where gas exchange occurs. The proteins, SPA and SPC, play roles in the recycling and reuptake of surfactant by type II pneumocytes, ensuring that surfactant levels are maintained within an optimal range. This recycling process helps conserve surfactant components and maintain lung function. Deficiencies or abnormalities in surfactant proteins can lead to severe respiratory conditions. For example, a lack of SPB is associated with fatal respiratory failure in newborns, as it is essential for surfactant function. Mutations in SPC can lead to chronic lung diseases, such as interstitial lung disease, due to impaired surfactant metabolism and alveolar stability. While SPA and SPD are not directly involved in surface tension reduction, Their absence can increase susceptibility to lung infections and inflammation. In summary, surfactant proteins are essential components of pulmonary surfactant, with SPB and SPC playing critical roles in reducing surface tension and maintaining alveolar stability, while SPA and SPD contribute to immune defense and surfactant homeostasis. Together, these proteins ensure the proper functioning of the lungs, enabling efficient gas exchange and protecting against respiratory infections. Now it is time to check your comprehension. Type 2 pneumocytes produce surfactant. True or false? True. Storage of surfactant occurs in lamellar bodies. True or false? True. Surface tension is decreased by surfactant. True or false? True. There are two main therapeutic approaches to surfactant administration in newborns. For very premature infants, typically those under 26 to 27 weeks of gestation, there is a high likelihood of developing respiratory distress syndrome. In these cases, surfactant is often administered as soon as possible after birth, usually within minutes. This approach is known as prophylactic treatment. The rationale behind this strategy is to prevent lung injury before it occurs. However, it also carries the risk of treating some infants who might not have developed respiratory distress syndrome. Clinical studies have shown that prophylactic treatment, when compared to rescue treatment, reduces morbidity and mortality in infants delivered before 30 weeks of gestation. The second approach, known as rescue treatment, is used for infants who already show significant signs and symptoms of respiratory distress syndrome. The advantage of this method is that it ensures only those infants who truly need surfactant receive it, and it allows more time to confirm proper placement of the endotracheal tube before administration. However, the downside of rescue treatment is that it may delay intervention, potentially allowing lung injury to progress before treatment is initiated. Both approaches aim to address respiratory distress syndrome effectively, but they differ in timing and the balance between proactive prevention and targeted treatment. The surfactant naturally produced in lung tissue is referred to as endogenous surfactant. In contrast, exogenous surfactants are produced outside the body and administered as a therapeutic treatment. Exogenous surfactants are categorized into two types: natural or modified, and synthetic. Synthetic surfactants are laboratory-created mixtures of synthetic components. While these synthetic formulations have the advantage of being free from infectious agents and foreign proteins, they may not perform as effectively as natural surfactants due to the substitution of organic chemicals for natural proteins. Endogenous surfactant is a complex mixture of phospholipids and proteins produced by type 2 pneumocytes in the lungs. It plays a vital role in reducing alveolar surface tension and preventing alveolar collapse. Exogenous surfactants, on the other hand, are surfactant drugs produced outside the patient's body, either derived from human or animal sources or synthesized in a laboratory. Natural surfactants are obtained from animals through alveolar wash procedures. The surfactant is then extracted from the liquid using centrifugation or filtration. To enhance its function in the lungs, reduce protein contamination, and ensure sterility, the surfactant is modified by adding or removing certain components. This preparation process is time-consuming, which contributes to the higher cost of the drug. Additionally, there are concerns about the potential for viral infection and immune reactions to foreign proteins. However, natural surfactants have the advantage of containing essential phospholipids and proteins, such as SPB and SPC, which are crucial for the absorption and spreading of phospholipids in the lungs. Both natural and synthetic surfactants have demonstrated effectiveness in clinical use. However, natural surfactants tend to act more quickly and are associated with lower mortality rates, reduced barotrauma, and decreased oxygen requirements. When comparing different natural surfactants in head-to-head trials, no significant differences in efficacy have been observed. Bovine and porcine-derived exogenous surfactants are both natural surfactants used to treat respiratory distress syndrome in premature infants, but they differ in their sources, composition, and preparation methods. Bovine-derived surfactants are extracted from the lungs of cows. One example is Biractin, otherwise known as Cervanta, which is obtained through a process that involves washing bovine lungs to collect the surfactant material. The extracted surfactant is then modified by adding synthetic components, such as additional phospholipids, to enhance its effectiveness. Bovine surfactants typically contain both hydrophobic proteins, SPB and SPC, which are essential for reducing surface tension and stabilizing the alveoli. However, the preparation process may involve removing or diluting some natural proteins to reduce the risk of immune reactions. Bovine-derived surfactants are widely used and have been shown to improve lung compliance and reduce mortality in premature infants with RDS. Porcine-derived surfactants, on the other hand, are obtained from the lungs of pigs. An example is Piractin alpha, which is known as Curosurf, which is extracted and purified from minced porcine lung tissue. Porcine surfactants are known for their high concentration of phospholipids and the presence of natural SPB and SPC proteins. The purification process for porcine surfactants is designed to retain these proteins while minimizing contaminants, making them highly effective at reducing surface tension and improving lung function. Porcine-derived surfactants are often noted for their rapid onset of action and ability to improve oxygenation quickly. The key differences between bovine and porcine surfactants lie in their source material, preparation methods, and the specific composition of their phospholipids and proteins. Bovine surfactants are often modified with synthetic additives, while porcine surfactants are more heavily purified to retain natural proteins. Both types have been shown to be effective in treating respiratory distress syndrome, but porcine surfactants are sometimes preferred for their rapid action and high phospholipid content, while bovine surfactants are valued for their widespread availability and proven clinical efficacy. Ultimately, the choice between the two depends on clinical context, availability, and specific patient needs. Calfactant is an exogenous surfactant derived from the lungs of calves, making it a bovine-derived surfactant. It is used to treat respiratory distress syndrome in premature infants, particularly those with surfactant deficiency. Calfactant contains a mixture of natural phospholipids, neutral lipids, and hydrophobic surfactant-associated proteins, including SPB and SPC, which are essential for reducing surface tension and stabilizing the alveoli. These components mimic the natural surfactant produced in human lungs, allowing it to effectively improve lung compliance and gas exchange. What sets calfactant apart from other exogenous surfactants is its specific preparation and composition. It is extracted from calf lungs and undergoes a purification process to ensure it retains the necessary proteins and lipids while minimizing potential contaminants. This natural composition, particularly the presence of SPB and SPC, allows calfactant to spread rapidly across the alveolar surface and restore lung function quickly. Its natural origin and protein content make it highly effective in reducing the risk of alveolar collapse and improving oxygenation in premature infants. Calfactant is administered via endotracheal instillation, meaning it is delivered directly into the infant's lungs through an endotracheal tube. The dosing is based on the infant's body weight, and it is typically given as a single dose shortly after birth, or as soon as respiratory distress syndrome is diagnosed. In some cases, additional doses may be required if the infant continues to show signs of respiratory distress. The administration process requires careful attention to ensure proper placement of the endotracheal tube and even distribution of the surfactant throughout the lungs. In summary, calfactant is a bovine-derived exogenous surfactant that stands out due to its natural composition, including essential surfactant proteins, SPB and SPC. It is administered via endotracheal instillation and dosed according to the infant's weight, with the potential for repeat doses if necessary. Its rapid action and effectiveness in improving lung function make it a valuable treatment for premature infants with respiratory distress syndrome. Biractant, marketed under the brand name Survanta, is an exogenous surfactant derived from bovine, cow, lungs. It is used to treat respiratory distress syndrome in premature infants, particularly those with surfactant deficiency. Biractant is a modified natural surfactant, meaning it is extracted from bovine lung tissue and then supplemented with additional synthetic components, such as phospholipids, to enhance its effectiveness. It contains the essential hydrophobic surfactant proteins, SPB and SPC, which are critical for reducing surface tension and stabilizing the alveoli, but some natural proteins are removed or diluted during the modification process to reduce the risk of immune reactions. What makes biractant unique is its modified natural composition. While it retains the key proteins and lipids necessary for surfactant function, it is further enhanced with synthetic additives to improve its performance. This modification process ensures that biractant is effective in reducing alveolar collapse and improving lung compliance, while also addressing concerns about potential contaminants or immune responses. Biractant is known for its ability to improve oxygenation and reduce the severity of respiratory distress syndrome in premature infants. Biractant is administered via endotracheal instillation. The dosing is based on the infant's body weight, and it is typically given as soon as respiratory distress syndrome is diagnosed, or as a prophylactic measure shortly after birth, in high-risk infants. The administration process requires careful attention to ensure proper placement of the endotracheal tube and even distribution of the surfactant throughout the lungs. In some cases, additional doses may be required if the infant continues to exhibit signs of respiratory distress. In summary, biractant is a modified bovine-derived exogenous surfactant that combines natural surfactant components with synthetic additives to enhance its effectiveness. It is administered via endotracheal instillation and dosed according to the infant's weight, with the potential for repeat doses if necessary. Its modified composition and proven efficacy in improving lung function make it a widely used treatment for premature infants with respiratory distress syndrome. Piractin alpha, marketed under the brand name Curosurf, is an exogenous surfactant derived from porcine, pig, lungs. It is used to treat respiratory distress syndrome in premature infants, particularly those with surfactant deficiency. Piractin alpha is a highly purified natural surfactant extracted from minced porcine lung tissue and it contains a high concentration of phospholipids, along with the essential hydrophobic surfactant proteins, SPB and SPC. These components are critical for reducing surface tension and stabilizing the alveoli, enabling efficient gas exchange and preventing alveolar collapse. What sets Paractin alpha apart is its high phospholipid content and the preservation of natural surfactant proteins during the purification process. Unlike some other surfactants, Paractin alpha undergoes minimal modification, retaining its natural composition, which allows it to spread rapidly and effectively across the alveolar surface. This rapid action makes it particularly effective at improving oxygenation and lung compliance quickly after administration. Additionally, its high purity reduces the risk of immune reactions or contamination, making it a reliable option for treating respiratory distress syndrome. Paractin alpha is administered via endotracheal instillation. The dosing is based on the infant's body weight, and it is typically given as soon as respiratory distress syndrome is diagnosed, or as a prophylactic measure shortly after birth in high-risk infants. The administration process requires careful attention to ensure proper placement of the endotracheal tube, and even distribution of the surfactant throughout the lungs. In some cases, additional doses may be required if the infant continues to show signs of respiratory distress. In summary, Paractin alpha is a porcine-derived exogenous surfactant, known for its high phospholipid content and natural composition, including essential surfactant proteins, SPB and SPC. It is administered via endotracheal instillation and dosed according to the infant's weight, with the potential for repeat doses if necessary. Its rapid action, high purity, and effectiveness in improving lung function make it a valuable treatment for premature infants with respiratory distress syndrome. Surfactant therapy, while highly effective in treating respiratory distress syndrome in premature infants, is not without potential hazards and complications. One of the primary risks associated with surfactant administration is the procedure itself, which involves endotracheal instillation. This requires the insertion of an endotracheal tube into the infant's trachea, a process that can be technically challenging and carries risks such as trauma to the airway, bleeding, or accidental misplacement of the tube. Improper placement can lead to uneven distribution of the surfactant, reducing its effectiveness, or causing complications like pneumothorax. Another significant concern is the acute physiological response to surfactant administration. During and immediately after the procedure, infants may experience transient changes in oxygen levels, blood pressure, or heart rate. These changes can occur due to the rapid expansion of the lungs. In some cases, infants may develop bradycardia or hypoxemia, requiring immediate intervention to stabilize their condition. Infection risk is also a potential complication, particularly because surfactant therapy involves invasive procedures, such as intubation and mechanical ventilation. These procedures can introduce pathogens into the respiratory tract, increasing the risk of infections, like pneumonia or sepsis. Additionally, while natural surfactants are purified, there is still a theoretical risk of immune reactions to foreign proteins, although this is rare with modern preparations. Another complication is the potential for airway obstruction during surfactant administration. The instillation of a viscous liquid into the trachea can temporarily block the airway, leading to difficulty in ventilation or oxygenation. Careful monitoring and skilled administration are required to minimize this risk. Long-term complications may also arise, particularly in extremely premature infants. While surfactant therapy improves short-term outcomes, These infants remain at risk for chronic lung conditions, such as bronchopulmonary dysplasia. Surfactant therapy does not eliminate the risk of bronchopulmonary dysplasia, as the underlying immaturity of the lungs and the need for respiratory support contribute to its development. Finally, there is the risk of overdistension of the lungs following surfactant administration. As the alveoli expand and lung compliance improves, there is a potential for overinflation, which can lead to lung injury or air leaks, such as pneumothorax or pulmonary interstitial emphysema. In summary, while surfactant therapy is a life-saving intervention for premature infants with respiratory distress syndrome, it is associated with several hazards and complications. These include risks related to the administration procedure, acute physiological changes, infection, airway obstruction, long-term lung disease, and lung overdistension. Careful monitoring, skilled administration, and appropriate follow-up are essential to minimize these risks and ensure the best possible outcomes for infants receiving surfactant therapy. During this presentation, we covered the following. Proper function of the mucociliary system is critical to maintain proper pulmonary hygiene. Bland aerosols can deliver high levels of humidity to assist proper function. Expectorants and antitussive agents can also assist in helping to treat pulmonary irritation and secretion problems. Proper functioning of surfactant at the alveolar level is needed to maintain proper surface tension to prevent both collapse and overdistension of the alveoli. Exogenous surfactant replacement therapy can prevent or treat premature or low birth weight infants with respiratory distress syndrome, RDS. I hope you have enjoyed this presentation.